care in Milan, in Italy, and he will, the topic of his talk is non-cardiac surgery in left ventricular assist device patients. Michele, the floor is yours.
Hello, good evening, everybody. Good evening, dear colleagues and ladies and gentlemen. First of all, I want to thank you, the organizer, for this kind invitation, especially Professor Helpahan for organizing this. So, my talk is about non-cardiac surgery in LVAD patients. Picture above is Milan Cardiac Transplant Center. And I have no disclosure. And so we heard and we've seen that the history of mechanical assistance devices now go a little bit back in time, and we can separate first, second, and third generation, which parallels different advancement in technology and advancement in function and size, which has broadened the number of people to which we can actually apply ventricular assistance devices. And some of them start to appear in museums as well. Together with the evolution of technology, also knowledge has grown. And we have, as we heard before, we know that this is a real alternative for patients with end-stage heart failure, and that in time, the evolution has proven that continuous flow has better result than pulsatile flow, to the point that basically since 2010, more than 98% of the LVADs implanted were non-pulsatile. And again, with improvement of technology, we now seem to see that third generation devices are better performing, or at least give us less complications. So this has led to the fact, to the logical consequence that these ventricular assistance devices are implanted more and more in time. And the 1 year post-implant survival has now reached 80%. And even the most recent publication, this is just published in 2020, which compare different centers between Europe and America, and at a follow-up at 5 years, show that a 1 year survival is even above 80%. So what does this lead to? It leads to the fact that the LVAD has improved therapy survival, as we know, has broadened the indication from the original bridge to transplant to destination therapy. And so we will have more and more patients needing non-cardiac surgery, and they will come to us for different types of surgeries. Most of them will be on continuous flow devices, and there is an increasing number of destination therapy. So what kind of surgery are we looking at, and what are the complications and the outcomes? Well, when we talk about non-cardiac surgery, we really talk about all kinds of possible surgeries. So this is an analysis from the National Inpatient Sample Database that dates a little bit from 2007 to 2010. And we can see that the most common surgeries performed were general surgery, thoracic and vascular surgery. And these patients do have more complication in general, especially more bleeding and infection. But in this analysis, the overall mortality was not statistically significant. But our population is of surgery, going through surgery, can be also analyzed from different point of view. In this study from Washington in 2017, we can start to see that we can select also our population into elective, urgent, and emergency surgery, and then complications seems to appear a little bit more commonly in emergency surgery. So that's also another fact to keep into account. Together with the timing of the surgery itself, if the patient comes to a hospital several weeks or months after the implantation of the LVAD, the complication, the morbidity and mortality are less compared to a surgery performed on same admission where it's usually more emergency surgery. This is an interesting paper published in 2020 on ASIO, again from the National Inpatient Sample Database, which looks mostly at major surgery. And as we can see, the number of non-cardiac surgery has doubled in the 4-year study, together with the numbers of implantations. But if we also look at other types of surgeries like neurological or head and neck surgery, they tend to appear more in the emergency surgery, elective and urgent surgery, And when we look at the overall mortality of major type of surgery, well, then it's not irrelevant. It's actually quite high. So we need to take in consideration many things when we look at the population that goes through non-cardiac surgery with an LVAD, and trying to optimize these high-risk patients in order to have less postoperative complications. So complications like acute kidney failure and infections are frequent and increase the morbidity and mortality of our patients. And urgent and emergency surgery is a risk factor for in-hospital mortality. So who should perform surgery for LVAD patient going to non-cardiac surgery? Well, there are some polarized opinions. There are opinions that it should always be a cardiac anesthesiologist, or that it's not necessary need a cardiac anesthesiologist, or somebody compared cardiac anesthesiologist fellow and general anesthesiology fellow and see what was the outcome. And I won't go through these numbers, which are a bit small, but basically, if they looked at the number of vasoactive drugs used, length of stay in a hospital, and so on, the conclusion is that there was no difference on outcome during low-risk non-cardiac surgery, suggesting that irrespectively of the subspecialty training, non-cardiac anesthesiologists might care for this patient as long as they have detailed knowledge of the LVAD physiology. Now, I think on this slide, two important things to look at is that we're looking about a low-risk non-cardiac surgery and detailed knowledge of the LVAD physiology it's necessary. So we need to know what we're talking about. So slide not going. So we've seen there are many different type of machines coming in different sizes and shapes, but the LVAD is not just the impeller. It also comes with a number of other parts that we need to keep in mind and to know fine when we are dealing with patients going to non-cardiac surgery. And depending on the vendor, the display of the main monitor can be different, but still giving us very similar information. And these are not just random numbers that we can forget about it if we're dealing with a patient with an LVAD, but we should try to understand what they mean because it's important. Now, for a matter of time, I won't go too much in details of these numbers, but just to let you know, pump power is the energy required to run the impeller and has a linear relationship between the pump power and the pump flow. And the pump flow is derived from the consumption. So is a surrogate of the pump flow. It's not true measurement of the cardiac output, but it is a surrogate with an algorithm. So that sometimes the information that we get, if there is an increase in pump power, can be wrong. So we need to understand what these numbers means and what they are. So when we look at recommendations from the International Society, basically it's recommended that during a non-cardiac surgery for LVAD patients, the LVAD team should be informed and should cooperate with the surgical team, and the VAD specialist should be in the OR or readily available. So meaning that most of these surgeries should really be performed in centers that are used to implanting and dealing patients with the LVADs. So moving on to how do we evaluate these patients? Well, again, it really depends on the type of surgeries we are looking at. And in general, we evaluate this patient like any other patients, but I want to point out some particular features that are key points to analyze. So first of all, anticoagulation management. These patients are on anticoagulation and antiplatelets. So we don't really have proper guidelines that refer to the type of surgery or the time of the surgery, but some suggestions. So some procedures can be performed with the setting or normal INR. The majority of procedures might have to be bridge from warfarin to unfractionated heparin. So we should stop our warfarin about 5 days before and then continue some heparin, which will be stopped on the day of the surgery. Anticoagulation reversal is